I've been very quiet because I'm in learning mode. My name is Jeff DeVelko. I direct the Environmental Change and Security Program here, and in those categories of other duties as assigned, where you also learn a lot of things. I coordinate our Global Health Initiative in collaboration with colleagues in the House, as well as colleagues like Vic Barbiero, who've been terrific as senior advisor to this effort. I'm have the pleasure of chairing our third session that is entitled Roles of the Public and Private Sectors in Africa's Health. I think we'll bring together that 30,000 view and the 2 feet view in many respects with some practical insights that Patrick Osewe, who's a senior HIV/AIDS specialist at the World Bank, with a presentation, a paper that he's prepared. And then Nancy Pielemeier, Vice President, International Health Division at Apt Associates, is going to be our discussant. Just a few words about Patrick and Nancy, and turn the floor over to Patrick. As I said, he's now at the bank, where he's been for 3 years. Before that, he was an AIDS technical advisor at AID, particularly focusing on Southern Africa. Experience as an epidemiologist with the CDC, global health professor, and an MD from University of Nairobi and MPH from Harvard School of Public Health. Nancy is Vice President, International Health Division, as I said, at Apt. She's been there for a number of years, but working right now, directing a big USAID project called Partners for Health Reform Plus. She joined Apt in '94. Before that was at AID, and with a number of postings, many of which were in Sub-Saharan Africa, and was an executive manager and senior policy advisor for AID, also here in Washington. Has a doctorate of public health, and international health, and MHS in comprehensive health planning from Johns Hopkins. So, Patrick, why don't we turn the floor over to you?
Thank you. I would like to thank the organizers for inviting me to share some of my thoughts with you on how to strengthen public-private partnership in the continent of Africa. I don't know why Victor chose me to give me this slot in the afternoon. This is usually the deadly slot for 2 reasons. First is because people suffer from the soft neck syndrome, whereby you just see people drooling like this, especially those who woke up at 4 a.m. to be here at 9 o'clock. The second reason is that, as you probably all know, is that the body has 5 liters of blood equitably distributed at every time, except after a heavy meal, when blood begins to flow to the stomach and less flows to the brain. And that also causes another situation whereby you find that people attention goes down. So it's a deadly session, but I would like to make it as interesting as I can, so that at least I keep you awake. Secondly, this is the first time that I'm presenting, and the discussant is a whole vice president. So I'm happy that Nancy, as a vice president, will be discussing what we're talking about. Now, I've grouped my presentation into 6 different contexts. First is just to talk about the context of health coverage in Sub-Saharan Africa. The good news here is that a lot of this has been discussed earlier, so I'll go through this very quickly. The second is the healthcare coverage, public versus private. There are lots and lots of myths regarding the public sector and the private sector. At the end, the microphone, right? Okay. At the end, I would like to unbundle some of those myths. Then I'll also talk about the types of partnership. I think that as we are discussing here, people are focusing only on one particular type of partnership, but there are more at various levels and so on. And then I'll talk about some of the challenges to implementation. It's easy to talk about PPP, but there are major challenges on how to implement it. And then talk about what are some of the current strategies and key issues and the way forward based on some of the experience. Just as a matter of further introduction, within the World Bank, I work at the World Bank Institute, working on the health and HIV/AIDS team. And we are responsible for capacity building for bank operations worldwide. And one of the initiatives that I'm leading is public-private partnership. And we've been doing this for the last 2 years, working with a variety of countries on how we can strengthen what they're doing in terms of public-private partnership. So I'll bring in some of that experience based on some of the lessons that we've learned as we've been trying to implement that. As you all heard in the morning, when most African countries became independent in the 60s, there was a lot of euphoria, there was a lot of excitement, and a lot of countries, if not all countries, enacted constitution that stated that healthcare was going to be free. Universal coverage of healthcare for everyone. Very, very noble goal. But the reality is that those goals were never met. And we know that we have major health crisis and plummeting health expectancies. Now, just to go quickly through challenges and to identify why I'm highlighting some of these challenges, is that we know that, as stated earlier, that there's a huge burden of disease. The biggest challenge here is that the public facilities are very, very few. There are very few public facilities. Most of them are either in urban areas, capital cities, provincial cities, provinces, and then districts. Below that, you really do not have infrastructure. A few countries have dispensary and health centers, but quite often, most countries do not have such facilities. There's also a very high turnover of health workers for a variety of reasons that have been mentioned earlier, partly because you also have HIV affecting health workers like everyone else, but you also have internal migration, people moving from, say, the public sector to the private sector, and also people moving from the countries to the developed world for looking for greener pastures and so on. And that in itself is a whole subject of our workshop, so I'll not get into the details of that. Now, the public sector, in reality, does not reach the majority of the rural population. In the morning, it was stated that there is a massive rural to urban migration, but except for Zambia and a few other countries, the majority of countries, about 70 to 80% of the people still live in rural areas. So if you have services that are mostly in urban areas, but then you have 80% of the people in the rural areas, you're still not reaching the bulk of the population. Now, there's a major capacity gap in terms of managerial capacity. The technical capacity might be there. The biggest challenge is that the management, at the managerial level, there's a big issue, and that's why a lot of money is stuck. You know, people keep on talking about money, that we need more money, but the reality is that a lot of countries have so much resources that they're not able to spend. Domestic budget, the domestic budget for health is a major challenge. We talked about in the morning that because of poor planning and prioritization and lack of the sector to be able to plan accordingly and request for resources is a major challenge. And therefore, the ministries of finance that have resources, quite often they say that they'll be willing to give that to the health sector. They can't because of the disorganization of the health sector. And then, of course, you have major challenges with the vertical programs that we all talked about in the morning. Despite the challenges, there are incredible number of opportunities. In fact, I would say that there are more opportunities than challenges as we try to untangle this big issue, how to engage the public sector, the private sector in the continent. Now, we all know that there's so much resources that are coming from the World Bank, the Global Fund, the US government, the Gates Foundation, the various foundations, increased resources at the country level, particularly for HIV, TB, and malaria. But some of the countries have been very smart in terms of using those resources, because when you're building a laboratory, the laboratory can cover everything. So you use malaria and HIV financing to build the capacity to have a state-of-the-art lab, and that lab can cover a lot of other things, similar to what Pfizer did in Uganda, the Tropical Institute. It's a state-of-the-art laboratory that's not just for HIV. It does blood tests for all other conditions in the system. So the university was very strategic in terms of using those resources to be able to strengthen the laboratory capacity at the country level. And I think that with very strong leadership and foresight, these resources that are coming in the country, although they're labeled HIV, TB, and malaria, could actually be used to strengthen the system to be able to take care of everything, including chronic diseases and so on. So that's an excellent opportunity. Quite often, sometimes, the managerial and technical capacity is lacking, or the flexibility is not there to be able to see how do you use the existing resources to be able to do that. The second opportunity is that the international organizations are interested, and they're also becoming flexible. At the beginning, there was lack of flexibility, but now you find that even the U.S. government, that's quite often is very strict in terms of how the money is used because of accountability to Congress, beginning to be more open in terms of using those resources to build infrastructure, to strengthen the health system and so on. And last year, the Global Fund Board actually agreed that their resources could be used to hire human resources. So the opportunities are there to be broader and to be able to take advantage of these resources that are coming from international organizations and international corporations and so on. Now, quite a number of countries are also going through a health sector reform. And the health sector reform has created a lot of opportunities to be able to focus on issues of management, financing, and linkage with the private sector, because the reality is that the bulk of the people go to the private sector. And I'll talk about that in a moment. And then the government are also beginning to look at their role as stewardship of health, not providing direct services. I was just sharing with some of you that in June I was in Pakistan, and we were meeting with very senior people within the Ministry of Health. And in Pakistan, 70% of the people are seen by the private sector, and only 30% are seen by the public sector. And so the question that I was asking the minister and his colleagues was that, are you a minister for health in Pakistan, or are you a minister of health for 30% of Pakistan? And everybody was taken aback. I said, maybe we need another minister, a minister of health for the 70% of Pakistan. So there's a big issue here whereby the ministries of health are beginning to see that they should play a stewardship role in terms of the health sector and coordinate the entire health sector, as opposed to only focusing on a small proportion of the health sector. And then the government is also implementing significant policy instruments to expand the private sector that I'll talk about soon. Now, health financing. We talked about the country's commitments to increase health financing to 15% of the government expenditure, and Kwaku was at that meeting and so on. The issues were highlighted why this is really a long shot because of the problems that we have in the health sector. There's a significant resource. The World Bank, just for HIV/AIDS, is 1.6 billion that's been committed. The Global Fund is 4.8 billion across 385 programs in 131 countries. Big resources. And PEPFAR, you all know, is 15 billion, mostly to Africa. So if you look at the financing over time from 96, this is where we are now, around almost $8.5 billion that is being channeled towards infectious diseases in countries across the world. Now, I want to focus on a few questions. And these are critical questions for us, especially as we will be discussing on what are the next steps. The first question is, who uses the public sector in Africa? Who uses the public sector? The second question is, who uses the private sector? Who finances healthcare? And how extensive is the reach of the private sector? There are myths about this. I mean, if you ask anybody in any country, say, who uses the public sector, they're going to say the poor. And the public sector has extensive infrastructure to take care of the poor people. Is that not correct? That's what people will say if you ask them. But let's see what's really happening. Now, who benefits from the public sector spending? If you look at the amount of money that goes into the public sector, the bulk of it, and part of it was mentioned early in the morning, the bulk of it goes to support tertiary institutions, intensive, heavy tertiary equipment-heavy tertiary institutions. And those tertiary institutions, the people that access them are mostly the urban elite. So you have a situation whereby you're spending significant resources of the state budget to support tertiary health institutions, which are mostly in the urban areas, but the majority of the people that are accessing those tertiary institutions are the urban elite. In some countries, 40 to 50% of the resources go towards tertiary institutions. And those tertiary institutions are not accessible because the bulk of the people live in the rural areas. So the people that are benefiting from the government subsidy are not the poor, but actually the rich. The majority of the rich are benefiting more than the poor themselves. The second thing that I wanted to say here, the private sector plays a significant role also in providing services for the rich, because that's what people have always said. But at the same time, it is providing a lot of services to the poor. Now, I'm going to unbundle what I mean by the private sector, because I think that in the discussion in the morning, that was also not very clear. I think there was confusion, people thinking the private sector is some sort of, these rich guys, the rich high-flying doctors and so on, or faith-based organization. But I'm going to get into that more in detail. In many countries, the NGOs play a very, very important role in terms of providing healthcare. If you look at the percentage of people treated outside the public sector for their most recent illness, this is the poorest 20% of the population. In Burkina Faso, in Chad, Ghana, Mali, and this is consistent in quite a number of countries, you find that more than 80% of the poorest people actually go to the private sector. I'll repeat. 20% of the poorest people for the most recent illness actually go to the private sector. This is totally contrary to the belief that the bulk of the poor people go to the public sector and the rich people go to the private sector. A review of demographic health survey from 20 countries showed that if you look at among those who sought care outside the home, who went to either private and public sector, you find that in many, many, many countries, the private sector plays a very critical role. And even some of the most poorest countries, like say Malawi, the bulk of the people, 74%, actually go to the private sector. Now, the percentages do not add up to 100 because there was a category called other, which is a small category, and anything that was less than 10% was excluded. So that's why the percentage did not add up to 100%. But this just underscores the fact that the private sector plays a very, very critical role. In some countries like Tanzania, that has invested very heavily in public health infrastructure and services and so on, you find that the number is reversed, where the public sector provides a lot of services. But in many, many, many countries, you find that the private sector plays a very critical role in health service delivery. So the question that we always ask ourselves as we work with countries and so on, and we also ask the countries, is how did we get where we are? How did we get to a situation whereby you have money coming from the state, from the Ministry of Finance, that's supposed to make services available to everyone, especially the poor in rural areas and so on, but we end up with a situation whereby the majority of the people who are benefiting are mostly the urban elite in most countries, not all countries, and that the poor people end up paying for services and therefore plunging themselves further into poverty. How did we get there? And these are some of the reasons. Over the years, as you all know, there's been decreased investment in public health infrastructure, major disinvestment in that area. Limited coverage in rural areas. In some situations, some countries have tried enough to expand health facilities to the rural areas. Nigeria, for instance, they have facilities up to the rural areas and so on, but there are no health workers in some of them. In fact, in South Africa, in some of the facilities in the rural areas, they've just decided to contract those out and let private sector providers run them because there were no health workers to work in such systems and so on. There's also a perception, and I think Dan talked about it in the morning, that there's a perception that the quality of healthcare in the public sector is very bad. I recall in my own country in the 80s, in Kenya, the public system was so bad that people used to walk with a tag or with a notice in their pocket that in the event of an accident, please do not take me to Kenyatta National Hospital, which is the main referral hospital and so on. Because if you went there, sometimes with the basic life-saving drugs were not there. So, people that the elite that had insurance and were able to go to good hospitals like the Nairobi Hospital and so on, they wanted people to know that if somebody comes and are incapacitated at the roads out on the roadside, they can take you to Nairobi Hospital you can afford. So there was a note in the pocket, please do not take me to Kenyatta Hospital. So people lost confidence in the public health system. The second one is that the health reform, as you all know, because of the structural adjustment programs by the World Bank and the IMF, there were caps on employment. And so that created a situation whereby the training was going on, the medical schools were producing doctors, and now the nursing schools were producing nurses and so on, and they were not being employed. And that led to a situation whereby you had health workers that were needed in this community and society, but they could not be hired. And as a consequence to that, they went to the private sector, sometimes to the rural areas and so on. So that created a fairly big private sector in some countries. Let's not forget about traditional healers. Traditional healers play a very major role in healthcare delivery in Africa, a very significant role. And in some situations, people actually go to the hospital, they get their drugs, and then they still go and see a traditional healer. You find scenarios, and we are dealing with this in HIV/AIDS, that people go and they get their ARVs, and then after the ARV, after going from the hospital, then they go and see a traditional healer. And then sometimes, we don't know, but we suspect that maybe there could be some interaction between the traditional medicine and some of the ARVs and so on. So the traditional healers continue to play a very significant role and are therefore a major part of the private sector. And then, of course, this positive perception of the private sector. In most places, if it's a traditional healer or if it's a doctor who has opened a clinic somewhere, they open longer hours. They're more accessible. They can operate until 10 o'clock. But I recall in some of the African countries, at 1 o'clock, the hospital is closed. You come the following day. And therefore, it's not accessible after 1 o'clock. In some places, after 4 o'clock, it's closed. So you have a situation whereby the facilities are closed at times when people might need them. And for those who have had children, sometimes they tend to get sick in the middle of the night. And so what are you left with is only a private sector facility at that moment. Financing. If you look at this graph, what you're trying to demonstrate here, in rich countries, in developed countries, see that the private sector out of pocket is fairly limited, only about 16%. 59% is the public sector. European countries, the UK and many other countries, the public sector is very dominant and so on. In Africa, you find that out of pocket is quite significant. Other private is about 7%. So 36% and 7% is about half. Basically, the message here is about half of the people that are sick. If you look, this is the data from 10 East and Southern African countries, and it's consistent in many countries. About half of the people actually pay for services themselves, and they go to the private sector. So it's quite significant that the majority of the people pay for their own health and they pay the private sector. Sometimes what they get is not the best, what they're supposed to be paying for, but that's where they go anyway. If you look at financing and the sources of financing, you look at the public, government, self-financing, and donors, and you look at the red bands here, you see that it's fairly significant that self-financing is a major, major issue. It's a major, major problem, and therefore people who are poor are getting poorer by the day. I'll go through this quickly because you have it in your transparency, in your printouts. But this is, when we are talking about private sector, we need to know what we are talking about. That we have two types of private sector. You have formal and informal. And then we also have those who are there to make profit and those are there not to make profit, but they're non-profit and so on. So therefore you have a constellation of many, many, many players, ranging all the way from formal, you have physicians, nurses and so on. Non-profit, you have various NGOs, religious hospitals and so on. Informal, you have traditional healers, traditional birth attendants, you have drug peddlers, and then you have community health workers and so on. I just want to mention something about community health workers. There was a discussion earlier in the morning about family planning, and I think that one thing that we haven't learned as we try to provide healthcare to, especially for HIV/AIDS, but also in other settings, is some of the most successful lessons in family planning. Family planning started in the 60s and so on, and most of the programs were fairly successful in terms of in terms of distributing contraceptives. And in many countries, you have community distributors of contraceptives, and Kwaku here was managing one of those programs, looking at how the community distributors of contraceptives can go door to door and distribute contraceptives and so on. Okay. Now, there are three types of public-private partnership, and I think that in the morning, people are thinking mostly in terms of the global ones. But you also have partnership at the national level, whereby various corporate or private entities collaborate with the government, and also the local level, whereby you find that, say, in some of the countries, the district, in decentralized structures, contract out some of the services and so on. This is how it's structured. This you all know, alliances with government, whatever, approaches and the agenda at various levels. The partnerships at the global level, these are things that you all know, for product development, for improving healthcare, and for global coordination, International Alliance for Vaccine Initiative, malaria vaccine initiative, and so on. Quite a number of initiatives at the global level. At the country level, there are several instruments that governments are using to try to engage the private sector. And that is basically to harness the existing private sector, which, as we've shown, is fairly extensive. The second one is to grow that extensive private sector, to grow it, using instruments to grow it. And third, conversion, whereby you're basically saying, let private sector entities run some of the district hospitals and health centers, that infrastructure that's already there. These are the instruments that you're probably all familiar with. Regulation, that has worked very well in South Africa, where you had a system before apartheid, that two systems, one for the Africans and the other one was for the whites, and now trying to bring all that into one formalized system. They used regulation very creatively to be able to do that, and to ensure that there's equity, to ensure that there were no disparities and so on. Contracting private providers is a big issue. Quite a number of countries are doing this. In Egypt, they have a social health fund that is contracting private providers to deliver care in the district hospital and so on. Social marketing and franchising, you all know. I manage one huge program with where PSI was in partnership with Population Services International, was in partnership with the government, and therefore providing testing, counseling and testing services, something that the government used to only test about 3,000 people per year. They moved it to testing about 20,000 people per month. So that partnership between an international organization and the government was able to build capacity and also to create demand, and therefore services were made available. The training of providers, this was talked about in the morning, that if you train the providers, because you have to recognize that when people have malaria in Ghana, for example, they don't go to a doctor. They just go to a pharmacy or to a shop and say that, give me malaria. Then you need to train such people so that they give the right treatment and so on. Ghana, actually, just to information provision, this is something that I wanted to mention because I think for HIV/AIDS, Ghana did something very unique. When grants were being given to the communities, they advertised in the papers that these are the NGOs that have received money, and this is why they received the money. For example, they've received money for orphans education, and they're supposed to educate 5,000 orphans. And this was advertised on the radio and so on. And when the NGOs were not being transparent, the community would go and say, you got money, we want to see how many orphans are you putting to school? Because the radio said it was so many number of orphans. Can we see? Really empowering the population to be able to make the government accountable. Challenges to implementation, I'll go through this quickly, is that lack of agreement on strategies to engage the private sector. This is one of the biggest problems. There aren't very good strategies at the country level. How do you engage the private sector? I mean, the private sector is not very well organized. And because they're not well organized, You have the traditional healers on their own, you have the faith-based on their own, you have the for-profit on their own. They're not organized, and therefore, how does the government engage them? But also, how do they themselves engage the government? Because of that lack of organization, that has created a problem. And then lack of familiarity with the private sector. We do public health, private sector health assessment, and we just realize as we talk to government officials that they actually don't know what is going on in the private sector. They have all this misconception about the private sector. You'd imagine that, these are their colleagues, they went to medical school together and so on. They actually don't know what is going on in the private sector. The other challenge is that, there's limited evidence. In some situations it has worked, but it's not clear whether those could be replicated. And I think this is something that we can discuss further. How do you, through this consortium that we are trying to put together, how do we document successes so that those can inform policy making, and policy decision making? And then there's also, if you now try to contract health services, contracting, for those of you who work in the public sector, is a specialized skill. To design, to plan, design, and monitor contracts. It's a specialized skill that does not exist in government. If you want to do that, how do you do it? And maybe capacity building of government officials, first of all, to be able to understand the private sector, and then to be able to learn the tools that are used to be able to engage the private sector is a good approach in that regard. The other challenge is that the public employees are unwilling to accept reform because they think they're going to lose power, jobs, and so on. And therefore, in the vertical programs, we talked about that in the morning. Now, let me just talk about some of the key issues. This is my second last slide. Victor, don't get too nervous. This is just to summarize some of the issues that I've talked about, that the poor seek care in the private sector. I asked a question earlier, but just to summarize that, the majority of the poor actually seek care in the private sector. And because of rising cost of healthcare all over the world, they're being plunged further into poverty. The health system is weak and cannot cope with the various epidemics and the increasing burden of chronic disease that Victor presented earlier. The population growth that we have is a strain on the health system, and the public facilities cannot cope. We need to engage, the countries need to engage the private sector. Building capacity on how to do that is a fundamental aspect of doing this. The opportunities the private sector are there to expand to the rural areas through incentives. We talked a little about incentives earlier. And then, of course, like I said earlier, the private sector needs to coordinate itself. Now, these are some of the thoughts as we discuss with various countries and so on, some of the thoughts that I would like to advance so that we can probably discuss further. How do countries implement some of these policy instruments that I've talked about? We're talking about issues of regulation, issues of training of providers. The issue that was discussed in the morning of the Ugandan experience, where you have the state-of-the-art medical training center and so on that I talked about earlier. When I worked for USAID, I actually sent 30 people to go to Uganda from Southern Africa to get further training there. How do we accelerate that, and how do we expand that? How do we create an environment that fosters this dialogue? If you don't understand each other, it's similar to our traditional lives. If you don't talk to your wife or you don't talk to your partner, you have a problem. Yeah. But so you need some enabling environment to be able to talk to each other to move the agenda forward. If you can't talk to your partner, there's no relationship. And therefore, we cannot have a situation whereby there's a common health objective of making the population healthy when people are not talking to each other. And then document some of the benefits of public-private partnership. There's very limited evidence. We've done a lot of literature search. People like Gilbert here, our associates have done that. So let's do that and see where we go. And then, of course, develop some sort of a partnership. I think this meeting is a good step in that direction. Partnership at the global level, at the national level, to be able to move the agenda forward. Thank you.
Thank you, Patrick. That's a lot of good unpacking of some of the important issues that have been focused on so far today. I think I'd like to just make sort of comments in two general areas. One is on the continuing gaps in the area of data availability and use. And then secondly, something more on the next steps that you referred to in terms of public-private partnerships. It's also helpful to be the last commentator, because then maybe I can guide some of the discussion for the group as a whole. In terms of data, I think this whole forum has provided us a very good sort of overview of particularly the problems and a very macro view of things, and Patrick has gotten it down to a little bit of a lower level, looking at some of the realities which are relatively new information. Interestingly enough, as a National Health Accounts groupie, I would have to say that I'm delighted to see the use of information that some of us have been laboring over for the last decade to really make available information from the country level to say what is happening there, what are the sources of funding for health, who's benefiting from their use. And we didn't have that information as much as 10 years ago until we had some considerable efforts that have been put forth on collecting information at the country level, so we can say all over Africa at more than 50% of the funds come from private sources, and most of that is out of pocket. And most people receive their care in the private sector. We knew that, but we couldn't prove that 10 years ago. And now we can. And that's just a really important step forward in the process. But I would like to encourage us to keep thinking about the importance of making sure that these data continue to be collected, and that we can then have time series and track over time to see what is happening in terms of the evidence-based issue that we talked about earlier as well. Secondly, another area that I think, again, we know, and we've looked at some of the macro data in terms of health providers. And I think that, again, we need to be able to unpack that a lot more. We know that there are in general too few health providers, and that they are poorly distributed, and that they are migrating or that they are moving around. And we had a reference today about they're moving from one set of health providers to working on some of these new initiatives. And so we are just moving people around as opposed to really dealing with the health worker crisis. So this is an area, and I was going to show you some, I don't know, maybe if we can pull up a couple of slides, some work that we've been doing, and actually led by my colleague Gilbert Comby here, and another colleague of ours, Slavia Chankova. We've just recently done studies in 5 African countries, all of them PEPFAR countries, where we've looked at the realities in the distribution of health workers within countries. And I was just going to
just use the
little doodad. Okay. Just going to give you just a little bit of a glimpse of the type of information that we've been trying to pull together to be able to then ground it more at the country level to say what is really happening here. We know there are not enough health providers, but where are they? What are they doing? How are we able to capture it? And mind you, what we've done so far is only collect information about health providers in the public sector. We are embarking on doing now in Cote d'Ivoire a similar study of the distribution of health workers in the private sector, which will be kind of groundbreaking, and we're hoping to do that in some of the other countries as well. But we see that attrition rates, for example, are very serious at all levels, physicians, nurses, and in other parts of the health system. Projected shortage of health workers. We see that that in terms of numbers of new professionals being produced and numbers that are leaving, that we're having a negative balance here, which is particularly acute. Interestingly enough, I mean, it's bad enough for physicians. It's probably worse with nurses and pharmacists and lab technicians. And this is particularly looking at the delivery of PEPFAR and other HIV/AIDS related interventions. So that's just to give you a little bit of an idea of some information that we've been working on, and that I think these are kinds of examples of things that in order to really be able to figure out how do we intervene, we need that intermediate level of information. We kind of know about the generalities, but what we need is really the information that is built at the country level, that is able to inform our decision making. So we have data that we can describe the problems. We don't necessarily have the data that are going to allow us to make the right decisions. And so that's an area I think we need to focus on. The second set of comments are around next steps on public-private partnerships. There have been reference today to the kind of partnerships between industry and countries. And I think that there are some very interesting things going on. I'm not sure that there has been enough sharing of experience and learning from those initiatives. And I think that would be one thing that we might want to think about as to a next step for a group like this. That what has Merck learned from their work together with the Gates Foundation and the government of Botswana? What has Abbott learned in Tanzania? What has Pfizer learned in the work that they have done? And then I think another area is to identify and learn from some of the initiatives that create intermediaries to link up the public sector and the private sector. And one of those is a publicly funded initiative, which is called the Private Sector Partnerships for Better Health, which some of my colleagues are working on, and I put some information on the table out here. This is funded by USAID, and one of the objectives of this worldwide project is to establish and facilitate public-private partnerships. And it is funded by USAID, and it is there and available to help make these link-ups. I think it's probably not as well known as it could be. One of the things that the project has done is to put together a wall chart with information on what's happening in the private sector. And I put copies of that out here too, and that pulls together some of this information from the National Health Accounts data, other data, to actually examine and compare countries in terms of what's happening with private sector health provision. And then I don't know much about it, but there's something going on with the IFC. And I think maybe that would be something that would be interesting to learn more about as well. And maybe you all know a lot more about that and can share that with us. And what about revitalizing some of the old partnerships? Certainly I was reminded from my earlier days in Africa as well about the Christian Health Association of Liberia, which is very similar to the Church Health Association in Kenya and in Zambia and in many of the countries. And somehow that's a little bit fallen off the screen. And those organizations played a very important role, and I'm sure still do, in terms of trying to link up the public and the private sectors. And how can we revitalize some of those relationships? And then some of the new mechanisms that Patrick mentioned about how to corral and use private sector providers. Certainly contracting. That is, if government is contracting with private sector providers, that allows that kind of stewardship and requires that there be some kind of quality measurement, which is another important concept that we need to keep in mind in terms of using the private sector. The reality is that in much of Africa, private providers are not as well trained in many cases because they don't receive in-service training. They aren't able to keep up with what's going on, that public sector providers get trained and retrained all the time. So there are issues around how do we make sure when we do involve private providers that we have a net gain from that in terms of the quality of services provided. And another area that I think we need to focus on is the area of accreditation, which is a way that you assure at least a minimum standard for quality and as you are contracting and involving private providers. So those are just a few ideas in terms of next steps, both in terms of making sure that we have and use information for decision making, and then in terms of where do we go from here. And thank you all for this great opportunity to really think through some of these issues, and hope that this is going to lead to an opportunity to follow up on some of these next steps.
Terrific. Well, thank you, Nancy, and thank you, Patrick, for